Well, welcome to the show, Travis. Thank you so much for taking time out of your very busy schedule to join us here this evening to talk about hip dysplasia.
Well, thanks for having me. It was a real pleasure to be with you guys and get to interact once again after many years.
Yeah. So today we're talking about the management of symptomatic hip dysplasia and specifically diving into borderline hip dysplasia, which is a controversial topic in the hip preservation world. So we recently did an episode on this actually at AOSSM, but that focused primarily on adult hip dysplasia and how we tackle that. So today we want to talk more about the pediatric world. So before we get into that though, we want to kind of start at the beginning with evaluation of a patient with suspected hip dysplasia. So, Travis, how does a patient with suspected, symptomatic hip dysplasia typically present? And how does that differ from, acetabular impingement, femoral acetabular impingement, like we typically learn about?
Well, it's a good question. Increasingly, we've realized over the probably last decade, 15 years, that patients with borderline hip dysplasia, mild hip dysplasia, as I'll just refer to it, they come in with kind of the usual hip pain you think you're seeing. That's overuse syndrome. They can be classic impingement looking things where they got sort of label based type symptoms, to frankly instability type symptoms, even though they have what seems like by numeric criteria not terrible under coverage, but more so in the patients that we're now more recognizing with ligamentous laxity, hypermobility, joint syndrome, EDS. They can honestly come in with these complaints like my hip feels loose. And historically, we feel like, the hip joint's a very stable joint, and we've all been that position where you actually have to dislocate or disarticulate a hip to do a hip replacement or whatever. And it's hard to do. But turns out some people, they're actually pretty loosey-goosey, so to say, and they actually have a symptom of true instability that really haunts them. And then with that, I'd say we've come to realize there are a lot of these patients who we've been seeing for years that have primarily, doesn't look too bad on x-ray dysplasia, but they're chronically haunted by muscle strains, abductor strains, hip flexor strains, like just muscles around the hip just are chronically irritated. They get better, then they get worse. I do some PT, maybe gets better, doesn't get better. And the growing supposition is frankly that this is frankly micro instability that's haunting them. Mm-hmm. So if we're just talking about the mild borderline dysplastic hips, these are the ones that are kind of hiding out in the weeds. And frankly, the ones that I feel more confident in saying that are needing more attention than we've been paying them over the last many years.
Yeah, I think that's really interesting that, there's a lot of different diagnoses that we have where there's just certain phrases or historical things that they say. And even before we do a physical exam, we're starting to think, like the spidey sense is saying, okay, I've got to really think about this. So you had mentioned, they just sort of feel this looseness. They're having sort of these strains and stuff. Is there also an age that you're seeing these symptoms type present, or not really?
It's a great question there also. I mean, we looked at this through the anchor group about onset of symptoms and timing of that. If I have dysplasia, when am I going to get my symptoms? When do we usually see that in patients that presented for osteotomy? And long story short, it's more or less a linear progression, and they seem to show up with symptoms in the late teens to the late 20s. That said, there's this group of other patients and people that do things with their hips that maybe stretch things out a little bit more actively. Our gymnasts, our dancers, our martial artists that are really pushing the limit with flexibility. And I see my dancers in their early teens from the local ballet schools and even frankly into the professional ballet world in the late teens have just really stretched their hips out so much that it's hard to believe what they can do with their bodies. And the physiologic range of motion for the hip doesn't incorporate that easily. So I think there's some component of it that they may present earlier depending on what they do for sports and activities. But I think fair to say that the average person, if they have dysplasia and they're going to get symptoms, can be late teens, late 20s, and frankly, later on into their 20s and 30s, frankly, or later 20s and 30s, where they hadn't had any problems before, and then they just, something happens, they get an x-ray, and now I have dysplasia, then what?
Yeah.
Mhm.
Okay.
Yeah.
So go ahead. You're going to ask.
No, that's good.
I was going to say, into the exam, what are you looking for like on exam that helps you suspect hip dysplasia? And like, talk to us like you talk to the residents and fellows, like what tests or exams do you really rely on that you feel like are most helpful?
So when I'm examining hip, one of the probably my biggest pieces is I think a lot of us learn hip exam in residency where you're kind of just moving things around and you kind of push this, I think it's there, and you're not really feeling the hip where it ends in motion. So it's literally just like two fingers on the knee and then enough support of the foot and ankle that you can just move around gently and feel where it initially makes contact. That's one. You pick up with, I guess, more on that. You'll pick up subtle things that even dysplastic hips will have that actually look like impingement. For instance, I in the OR you get a good exam, but the best exam. But someone flexes their hip, they look like a super flexible person. They got high anteversion, whatever on the imaging you cheated on when you went before the exam in the clinic, and they're like, this person's got dysplasia or whatever version of dysplasia and high anteversion, they should have great motion. But when you actually get to 90 degrees of flexion and you try to just tap the adduction, they have no adduction, they have no internal rotation despite high anteversion. That's one of these little subtle things you pick up when you really are careful with your exam to know that, yeah, they may be a little bit undercovered in one area, but they actually are overcovered in another. So the careful exam of the hip really is just a nice, gentle, easy range of motion piece. Impingement related testing, this flexion, adduction, internal rotation, etc. I think we all come to know that it's really more of a test of something symptomatic in that anterior region. It's not necessarily a labral tear or iliopsoas irritation or rectus irritation necessarily by definition. It's more just that you're identifying something that's sore in the front. And then finally, we got to be careful and understand what's going on in the back of the hip. Hal Martin and others now really pay a lot of attention to the posterior hip and posterior hip syndromes. And those can be probably the most challenging, frankly, worth an entire other discussion. But I guess the reality is basic range of motion testing is one thing, looking for the subtle areas where you might be missing motion that you should have. And then from there, a good muscle exam. The patients that have chronic muscle irritation, it's like palpating all the muscles from abductors back to front, and then hip flexors in the front, isolating the rectus and TFL and iliopsoas just by palpation. And then when you're looking at the hip flexor in particular, patients that have iliopsoas tendonitis, that sort of thing, when you're palpating at the rim or below the rim, I tell them, look, know that when you're pushing on that, the labrum is literally right below it. So if you have a labral injury or even worse, like a perilabral, so something like that underneath, and I'm jamming on that, I can't tell you for sure if that's a tendinopathy or it's a labral irritation or something else. But one little subtle thing you might actually help you out is you're palpating below the brim, it's on the labrum, but you palpate above and you've got just muscle. So they can actually have both. And trying to line up for them what are the possible things that are irritated here, I think also conceptually helps the patient understand what they're dealing with and why you're treating it one way or another.
Makes sense.
So you referenced cheating a little bit and checking the imaging before you evaluate the patient, which we're all guilty of. So we want to talk a little bit about imaging now. So dysplasia, typically what we learned historically back in the day is, you use the lateral center edge angle to diagnose dysplasia, with borderline being 18 to about 25. But our first paper by Michael McClincy at Boston Children's Hospital, where you are, found that the lateral center edge angle of 18 to 25 degrees, those patients frequently have other radiographic signs of dysplasia, like abnormal femoral head coverage of the acetabulum, problem, suggesting that if we put them in the borderline category, it may be misdiagnosing them. So what are you looking for on imaging, radiographic imaging? Let's start with that. Besides the lateral center edge angle, to really appropriately categorize these patients and determine the best treatment?
Boy, that is probably one of the best questions to ask from my standpoint, because full disclosure, I'm part of this anchor group out there for the multi-center group that looks at hip dysplasia and impingement. And even amongst our group, there's still some discussion about, does an anterior center edge angle matter? Does it really tell you anything? Does it really measure what the problem is? I'll just come right out and say, I tell folks, you can't tell me there's no dysplasia until you show me an anterior center edge angle of some variety. Now, obviously there's parts on the anterior rim that can be different. And so if you go deeper, you can look at things like the anterior wall index as opposed to anterior center edge angle. But truthfully, if it's me and I just want to tell somebody, what do you need to get? If somebody walks into your office and they have hip pain, what's my hip pain radiographic workup? It's a standing x-ray, AP pelvis. Dysplasia is a weight-bearing problem, so I want a standing x-ray. Moreover, we know that in supine, the pelvis is rotated forward because most of us have increased lordosis. That can artificially increase our anterior and lateral coverage. So I want a standing x-ray of the pelvis. I want a false profile. And when I give this talk to folks, like, well, my radiology team doesn't know what a false profile is. It's like, well, do what we do here, what Dr. Millis has gotten our guys to do, which is basically a standing iliac oblique Judet. That'll get you that. And then some version of it done to look at CAM. But that's a basic radiographic workup. Then you can add in additional things, advanced imaging, MRI and CT. Very commonly, folks will come to me with maybe a supine AP pelvis in an MRI, and they were told they have a labral tear, and someone said, maybe you have dysplasia. And then I just complete the radiographic workup. But I guess to your point, basic x-rays get us most of it. And I probably had this discussion at least half a dozen times a day with patients. Like, you have x-ray evidence and it looks like there may be some borderline dysplasia, but what we're still trying to figure out is we have all this advanced imaging like CT scans and 3D modeling that should be able to show us subtle areas of undercoverage, and how are we going to best utilize that to determine whether or not somebody's undercovered is still a work in progress. One probably big leap that we've been able to make here is that our team has developed a program now we're still validating, but essentially they dug into Children's Hospital archives and they found thousands of CT scans that were done for appendicitis or other things. And they archived that and they dumped it into the system. They said, okay, let's demographically match them to your patient. And then now it can generate a 3D model that shows you roughly 95% confidence interval where most people's acetabulum would cover your femoral head based upon your modeling. So what that's getting us now is that, first off, getting back to your question, basic imaging is a standing AP pelvis and false profile. On your standing AP pelvis, you're not just looking at lateral center edge angle. You're looking at the tonus acetabular sourceal angle. You're looking to see if there's a crossover sign, looking for subtle evidence of acetabular, like cephalad retroversion. That combined with the ischial spine sign, where you're seeing the ischial spine, that tells me I got to go looking very critically at their physical exam to see whether or not they're actually impinging in some way or another. Even though their lateral coverage may be a little bit deficient, they could still be overcovered in another area. And then, is the posterior wall sufficiently covered? Yeah. Posterior superior undercoverage is one of those like hiding guys, where if you look at it, the lateral center edge angle, you go to the sourceal, looks pretty good. But then you notice, like, man, there's a crossover sign up there. The anterior wall is crossing over the posterior wall. Posterior wall is pretty vertical. And if you actually measure to where the posterior wall comes up to meet, it's actually now your center edge angle is really dysplastic. So that is actually a true area of dysplasia where people just oftentimes don't pick up because you eyeball it. And if I just make one more big piece here, I'm telling folks, look, they came to you for the answer. You're the professional. Saying it doesn't look too bad is not sufficient anymore. You got to put the numbers on it. You're the expert. They came to you to figure it out. So if it's not dysplastic by numbers, you put the number on, good to go, as far as I'm concerned.
Nice.
I think, you brought up a lot of great points. And I think at the heart of it is X-ray tells us so much. And I know, for say knees, Ashley and I have talked about this a bunch where, you get someone that shows up at clinic with just like an MRI and the MRI was done. At least in Colorado, you can order an MRI as a physical therapist. So I don't know if I can't remember if you can do that in Massachusetts, but
You can't do that in New Jersey.
yeah. Okay. So it's unique. So sometimes you'll say, I also need x-rays. I need standing x-rays. I need long leg, or, depending on what the problem is. And there's a little bit of why, but it's all there, and there's just so much, to get, from all those standing views and, everything that you just pointed out. So I think that's always a hard discussion because but there's a labral tear in my MRI and that's all you need to know. Right.
Entire discussion about that.
Yeah. So I think super helpful, like just to go through all those things, because, you just had a huge list of like, hey, these are all the things I'm looking at. And if we skip those simple steps, you've lost a lot of the value of the workup. But when you do get that advanced imaging, I think that's what we want to tease out a little bit is, obviously sometimes they're coming in with it, but CT scans, specifically in the pediatric population, we're not ordering those willy-nilly. What makes that decision that you say, what, we're going for a CT scan or we're going for an MRI? If they've come into your office and you started the workup all on your own, and just on the x-rays thus far, how do you make that determination of they need advanced imaging?
Sure. So a couple pieces I'll just bring up. One, this surgical management of borderline dysplasia really is like a older teen to adult problem. We at Children's, we're a pediatric institution, obviously, but you guys have seen that we'll operate on patients that are at age 35, and if they're an older kid, then I take them up to an adult hospital. So the workup for that, from an imaging standpoint, I guess, as you brought up, MRI is very commonly what they show up with. What we are looking for is not just the MRI or CT scan, but now increasingly, almost universally, we'll get something that's MRI or CT that includes the femoral condyles. So we can look at femoral version, torsion, and just note that as whether or not there's something else that might be playing a role here. Posterior hip pain, for instance, I mentioned briefly the posterior hip syndrome stuff, but people come in with buttock pain and they have the posterior superior undercoverage. For instance, I want to know if they have something where their antetorsion is like 50 and they may be pinching in the back as opposed to whether acetabular dysplasia is an issue. So we want 3D imaging that would include bony morphology, and in most places I'd say probably easiest to get through CT. We've now our radiologists have developed a protocol where we can send out our images that are off of MRI sequences, and we just now call it a bone MRI, and the post-processing generates a 3D model of the pelvis and femurs, just like a CT scan. So want something that would show us the 3D morphology one way or another from a bony standpoint. And then the soft tissue imaging piece, looking at labral pathology, injury, that kind of thing, is the other part. One last piece is patients older than 30 and our long-term follow-up data after PAO and the Swiss data as well. When we talk about failure of PAO to help out, and our failure of PAO is progressive arthritis to hip replacement. Biggest risk factor is already having arthrosis beforehand. And MRI has developed a lot. I tell patients, look, we're still not perfect at looking and grading health of cartilage. And probably the best way we still have is, frankly, one of two or maybe three different ways of MR imaging of cartilage that will give us some hint of the relative health of the cartilage, whether it's degenerate or T1 row or etc. But something that will give you at least a little bit more insight in the relative health of the cartilage that's in there, because again, you want to have that conversation with the patient if they're dysplastic and they're 39.
Yeah.
What are they looking to get out of their PAO? I think my oldest PAO patient so far is 49, and good-looking cartilage. They knew what they wanted to get into. They didn't want hip replacement, and they're doing fabulously well. But they also have to have that understanding, like, what could I possibly get into, and what's my sort of relative cut point for success. So that kind of gets back to, for me, the imaging piece. Like, age plays a role as far as what type of MRI I want. But then also the 3D imaging part, where I'm trying to make sure I'm not missing something else that could be going on from a overall anatomy standpoint.
Got it. Yeah, that makes sense.
Yeah. So that segues nicely into our next discussion, where we want to talk about decision of treatment, specifically how we guide our patients. Like you mentioned, right? They're seeing you as the hip specialist. They want some answers. They want to know what to do moving forward. So there's been a lot of studies looking at the link between FAI and progression of hip arthritis. And there's also been some studies looking at hip dysplasia and its link to progressive joint damage and hip OA. And PAO has been shown to reduce this risk. So, I get a lot of times, I'm sure Catherine gets this too, not for hip, but for like knee, like, doc, like, am I going to hurt myself by not having surgery on this? Am I going to like have long-term issues and need surgery in the future if I don't have this addressed? So I'm sure you get that question a lot. Are you typically still starting with non-surgical treatment for these patients, or are there some kind of factors that would push you towards immediate surgery from a joint preservation perspective?
Sure. When we're just talking about mild hip dysplasia, my story I tell the patients is this. I jokingly say, my wife dragged me around all these long distance races for years, and I banged on these hips in the military for a while. And at 50, I, by accident, found out, like, I got imaging of my hips that included my hips for an unrelated reason, and there was bilateral hip dysplasia. Like, center edge angle is 19, like dripping with irony. And I was training for New York at the time. I was like, this is kind of telling as a hip surgeon that not all mildly dysplastic hips have to have a corrective osteotomy and to get you a good life out of it. Like, you can be active and not kill yourself, but some do. And one of the things we're working on now and still trying to figure out is which one of those hips needs something more.
Yeah.
Right. Yeah. And I think that's kind of borne out in the literature we have so far. We talk about arthroscopy in the setting of mild borderline hip dysplasia. And we can talk about that stuff, or you probably may bring up later. But how I talk to them, I was like, look, we start with non-operative management in everybody. And if you have borderline or mild hip dysplasia and you got pain, and you more often than not, you reached me via sports medicine person who they had hip pain, got an MRI, said, you got a labral tear, go see, Ashley or Catherine, and they got to fix your labral tear with arthroscopy. But they say, no, but you got hip dysplasia, go talk to Travis. And so I have the discussion, and I said, look, non-operative management's never off the table. If you can find a way to modify life or do life, PT, figure this out, work and sort itself out, especially if it's primarily muscular stuff to start. You do that always. Stay out of an operating room. The surgeries are very safe and they're well-walked road, but they're still surgery. And if you can figure out a way to do life without it, then do that every day of the week, twice on Sunday. But at the same time, there are some hips that won't respond to that. And that's part of the decision-making process.
Yeah, I think that makes a lot of sense. And especially in our pediatric patients, that's, even more so, trying to make sure that the surgery is the right answer for them and doing those trials of non-operative management. So let's talk a little bit more about that non-operative management. So if you're going down that path, for a patient with symptomatic and it's borderline hip dysplasia, what types of things are you telling the PT to work on? Obviously, you're at a great place where the PTs know exactly what to do, but not everybody has that set up, and they need to provide a little guidance. So what sort of programming do you do for these patients?
It's a great point in there that we do have some fantastic PTs. But that said, the vast majority come from areas, even around Boston or elsewhere, that have never seen a PAO, don't really understand dysplasia, and they come with a wide variety of experience. I'm sure you're very familiar with, Catherine. But
Yeah.
the truth is, I have to tell them, like, look, one of our theses is the muscles around the hip are irritated or maybe more irritatable in dysplasia. And our idea is that instability is causing that, where the muscles are really designed to just move the hip. So now they're being double tasked to help stabilize the joint and do regular daily activities. So I tell them to really just hammer the daily activity motion strength. Like, you need a good hip flexor. If your hip flexor is irritated, do stuff that doesn't aggravate it right now. Get it back to resting state, then build it back up.
Mm-hmm.
Abductor strength is huge. Like, classically, the abductors were felt to be the biggest problem, and you'll see that in the old textbooks. But frankly, you think about how that came out, it was more of like the high-grade dysplasias, because they clearly have a mobile center of like motion, like they're biomechanically dysfunctional. So that said, I think that still affects the borderline of mildly dysplastic hips. So I tell them I want good hip extensors, I want good hip abductors, I want good hip flexors. And beyond that, if they work on core strength and proprioception and some basic thoughts about gait training, then that's all good. And if they can get to where they want to be with just that, I think that seems to, at least in my experience, conquer a lot of it.
Yeah, it makes sense.
So PT obviously plays a really big role, but in the adult hip world, FAI or symptomatic dysplasia, injections are also a big part of the non-surgical treatment. So obviously we want to avoid cortisone injections in younger individuals. But Travis, are you ever considering like a hyaluronic acid injection or a PRP injection for these cases to kind of help them as they're doing the physical therapy?
Great question. We have a primary care sports medicine group, as I'm sure you guys remember, and Pierre Demoncourt is still the head of that, and he really has
That's
leading.
amazing.
I
Yeah.
know, he's still around, he's still cranking,
Wow.
and he really charges forth a lot of that and has been working hard to figure out whether or not we've gotten a lot of benefit out of it. I don't know if I can say that. My sense of the science is that we're to a point that I would throw that at a dysplastic hip to mitigate symptoms, because truthfully, I think I'm a biomechanical believer, and they could present with a biomechanical problem. And if you have a labral tear, it's probably because you're overloading the labrum or something similar, but aside from an activity that did it directly. So if you really want to just try to mitigate symptoms, then I suppose that's something you can try. But honestly, from an injection standpoint, our sports medicine group has also kind of evolved this hip ultrasound testing program. And they're essentially just they'll do dynamic hip ultrasounds. They've sort of validated the model looking at instability. They've helped us a lot from that standpoint. I think that testing from a dynamic instability standpoint, fair to say more specific than sensitive, but they can help us out to some degree. And then they'll also augment it with diagnostic injections. And when I send somebody for that, I literally send them just for the local anesthetic. I've had too many patients come back with a steroid flare and just said, oh my God, they gave me the injection and I'm miserable for 2 weeks. And what I really want is the diagnostic piece. I'm just trying to hammer out like how much of your pain is possibly coming from an intra-articular source that may not really respond to the PT we're going after.
Yeah, it's hard for me to wrap my head around the utility of like biologics for this problem, but I know, we're still learning so much about biologics, and I'm with you. It's like the biomechanical sort of side, just really sort of like, this is like, not to be hard-headed, but you're sort of like, this is a biomechanical problem. We need a biomechanical answer.
I'm with you. I'd love to hear. I mean, one part of my spiel is like the patient's like, you got two types of cartilage in your joint, and one we can repair and or reconstruct, and it works great. The other one, we still don't have a clue what to do with. And it's such a fantastically engineered substance that it's so much so we still can't fix it, we can't repair it. And so if we can find a way to regenerate it reliably and make it work, man, I gotta open up more time.
Yeah.
Awesome. Well, that really oh, so you were going to say, Catherine, go on.
Oh, no, I'm going to cut out the part that I'm just going to say next. But
Oh, gosh.
all during fellowship, I got assigned a study to go do rabbit surgery down in Houston. Dr. Philippon, I would have to fly down there for like a day and do rabbit surgeries with all these different injections for cartilage and losartan and all this sort of stuff. And I'm not like a vegan or, anything like that, or like, I understand the importance, but that's not what I want to do. Like it's upsetting to me, like to be the person actually doing it, like just like,
yeah. I've seen the day
like,
on Losart. I've seen Mark present that. It's impressive.
Isn't
That was me doing bunny
That was
surgery.
you.
Oh,
For like a year, and my co-fellows knew that, like, of course I never said anything to Philippon. I would just be like, of course, yep. But I would be like leaving in the morning to like fly out of Vail, and they'd be sending me all these like cute bunny pictures and like,
oh my gosh.
picturing me. Oh, all right.
Oh, geez.
Anyway,
Are we timing back in?
we're coming back in. It reminded me, like, I'm sorry, one last thing to time out. We both, Ashley and I, are close with Mark Price, and we had him on early on, and he did some timeouts on like, I know this is what we say we do, but this is what we really do. And if your X-ray on your Latarjet does not look okay, it's okay. Like,
don't even get imagery.
Yeah, there you go.
He's like, it happens. Like, it's fine.
Or when he's like, all the hockey players want Latarjets and all the Patriots want Bankarts. So I just give them what they want. Yeah. Don't say that. Take that out. We're like, okay.
Now that's a player tell.
Oh, so good.
Anyway, okay, timing back in.
Okay. So now we're going to shift our discussion to surgical treatment options. We're going to get to the fun stuff for symptomatic borderline hip dysplasia. And now is where we get to the controversy. So historically, hip dysplasia is treated with a periacetabular osteotomy to correct the shallow socket. However, there's growing interest in soft tissue management alone for this condition. So let's talk a little bit more about this. So Travis, you kind of alluded to this earlier, but if dysplasia is the underlying issue, why are we not just treating everyone with a PAO? What is the benefit of doing an arthroscopic surgery rather than just correcting the underlying problem?
Benefit of arthroscopic surgery over periacetabular osteotomy. One, it's a hell of a lot less painful, in my experience.
Yes, I would agree.
Face surgery, you're weaning off your crutches after a couple weeks. You're hitting that glide path pretty steeply for moving faster. In the presence of hypermobile joint syndrome, EDS, Chris Larson's actually published some nice stuff looking at potential benefits of adding in capsulorrhaphy to tighten the soft tissues around it, to aid in the recovery, and also long-term benefit, or at least mid-term benefit. So you can get a lot out of a less invasive surgery with arthroscopy in the setting of mild and borderline dysplasia. And once again, I always go back to my own life experience. Like, I recognize that not all mildly dysplastic hips have to have a big surgery to correct them to get a long-term benefit. That said, I think we're still struggling to figure out who does and which hips need more. When I talk about the PAO, and my discussion with patients is, look, there's non-op, there's scope, and then there's PAO plus or minus a scope or arthrotomy to address whatever label stuff you got. And each one are safe. They're medically okay to consider. No one's going to fail me on my board exam if I tell you to do one or the other, because you have a condition that's not life-threatening. There's data to support each one of those paths. So if we think, well, what's beneficial then of a PAO or arthroscopy? is there truly a study that shows that arthroscopy or PAO is going to beat arthroscopy? And I don't think that's ever going to happen, honestly. We're trying to look at that in the anchor group or indirectly, but no one's ever going to know the denominator. And getting an accurate comparison of apples to apples in somebody that's going to do arthroscopy versus PO, it's just going to be hard. And if for nothing else, when I talk to patients, I tell them, look, I like to win. But the win, honestly, in these situations for me is after we give them all the information about the non-op, but then also the different surgical options and what the data seems to show so far as benefit, that they get to go home and think about it. And then the win comes when they choose their path. And then on the far side, whether it's going awesome or they're still struggling with whatever PT part or something still aches a little bit, whatever, they can still look back and say, yeah, but I made the best decision for me. This made the most sense. And that mental investment, that sort of understanding of why I did what I did, I think truly carries the day. I think we're literally in borderline. I even almost hate to say borderline because I think you put that PowerPoint I sent you. I think it's true. Like it's like saying you're borderline pregnant. You're not borderline pregnant. You've got dysplasia. And this number of 25 degrees, by the way, it's like not like we're surgeons. Like we like all are we're on off. It's red. It's good or not good. Yeah. It's a gray zone. But that said, it's truly like something you could kind of do one or the other. And they both have great benefits. One has biomechanical benefits that I think are more solid, truthfully, from a bone perspective. The soft tissue piece can certainly help to make you feel a lot better in the short term. And our hope is that it gives you long-term benefit, but we're still trying to figure out what's going to give you the best result. And so what's the win? It's going to be what makes most sense to the patient.
Yeah. And I think you made a really good point there about that people can do well with arthroscopic surgery but it may not have that longevity, because I think it's important if people who do hip arthroscopic surgery know this, because a lot of times they'll see dysplasia and, like you said, just send to someone for a PAO. And like in my area, there's like one person that does PAO, right? And so like if arthroscopic surgeons can address these borderline cases, if they're armed with this information and can counsel patients, and then the patients select the arthroscopic approach, they can save those patients from having to be referred out and travel, miles and miles and hours to get to a PAO surgeon. So, I think you're putting the decision in their hands.
For sure. Excuse me. Certainly, having access to a PAO surgeon is one of the real decision notes, honestly. Yeah, and for sure. We're fortunate we have several in our area. And in the Eastern Seaboard, there's a bunch. But as you point out, like you're in New Jersey, like it's a populated area, but closer to your practice, you've got one person you have access to. Where do you go? If you're in Denver, you got a couple people, and then beyond that, you have to figure out what's going to happen to them post-op, who's going to care for them in their rehab. So, yeah, you're right. I mean, there's a lot more people doing arthroscopy, and it's a procedure that a lot of PTs feel very comfortable rehabbing. How I deal with that piece of it, I simplify as much as possible, because people do come from all over to get their PAO. And not to go too far off topic, but how do you make that part happen? Well, you tell them, like, you got a broken pelvis. I fixed it. And the doc says it's okay to start getting on it and rehabbing it. So here's a green light. Start progressing your weight bearing, increase your range of motion. And it's about as simple as that. And when you make it doable for the general folks out there, it makes it even more accessible. But I guess to your point, actually, you really have to have a person that is comfortable doing it and also has a volume doing it, frankly.
Right. Oh, yeah.
Yeah.
Yeah. I think it is a rarity. It's a rarity that you have a place where both is done in the same institution. If you look around the country, like, you're not always seeing that either. There's, as you indicated, there's plenty of places that have a hip arthroscopist, but, just because they're doing hip arthroscopy doesn't mean they have anyone in their institution doing a PAO. So when you're trying to have that communication, to help that patient, that can really get broken down and be really confusing and overwhelming for the patient.
Mhm.
But let's say, okay, let's talk about like the arthroscopic sort of side, and you determine, all right, this patient's appropriate for arthroscopic management. And that's what the patient wants. What do you think is key to manage or like address, like, as far as like capsule management, labral repair versus reconstruction, like, what do you think pretends when you're going that route a good outcome?
Well, that's a good question. It's back to the top, I guess the title of that talk I sent you guys.
Yes.
I got that title. It's like, when's mild dysplasia, borderline dysplasia, when's arthroscopy not enough?
Mm-hmm.
Coming to understand like how people manage that around the country, there's obviously some variation. One, you go in, you fix the labral tear. That what you think looks like an unstable labrum. Somebody who's got hypermobility, paying a little bit more attention to capsular management, trying to use either Mark's double row or like whoever's version of capsular ortho you like, and tighten that thing up a little bit and buy that extra soft tissue stability or regain it, what they used to have before maybe it got stretched out. Labral reconstruction, for me, is a pretty reserved option. Understanding that in other places, even out where you are, that there are folks who just say, let's just replace the whole thing. You get rid of the primary pain generator, you don't have as much possibility of pain later on. And I think there's logically some merit to that. It's just a different procedure that maybe we still have to figure out the merits of it overall. So treat the symptomatic thing, whether it's repair or replace, whatever's in your wheelhouse, and then think about the soft tissues around the outside of the joint. If they're a hypermobile person, probably better to consider tightening things up.
Makes sense.
So now for the bony side of things, periacetabular osteotomy, how, and talk to us like we know nothing about PAO, because I don't know about you, Catherine, but I know nothing about PAO anymore. I did when I was at Boston Children's in residency, but it's all gone away. So how are you determining your approach for the PAO? You're like what you're correcting. You mentioned they could be dysplastic in one area, impinging on another area. How are you determining your approach? And then like, what does your postoperative protocol look like for that patient?
Sure. I think this piece is really what's evolved the most over the last 10 to 15 years. And part of my spiel to patients is that, PAO has been around for 40 years. And the folks that, at least in my initial studies and the Swiss studies that you see out there that have long-term data, borderline patients are not in there. Right? And why is that we weren't sure how well it was going to do. There were only a few people doing it. So the evolution of that, I compare to hip replacements, where few people were doing it, you had a long inpatient stay, and then you evolved to this place where now several people can do it. You have a average, 2-day stay. Some people are trying to do some of this day surgery in the last 10 years, overnight stay. But essentially, the perioperative protocol, how you manage it, has gotten to a place where I feel honestly, it's gotten more palatable. You can offer it to people with borderline dysplasia and mild dysplasia, not feel like you're blowing up their life.
Yeah.
So first off, your indications and how you can indicate them really has evolved based upon what we can do with it now. It's not like a 6-7 hour surgery. It's an hour and a half, and then the hospital say a couple of days for us, just because we want to make sure that they can get going and be comfortable. Different hospitals do their perioperative pain management differently. So single shot block versus what we have now. And then like a home catheter program, like they go home with the pain ball and they can hang out with that for 5 days. Like there's been some changes like that help us to feel like we can more comfortably give this patient something that they couldn't have or wouldn't have been offered before. Next, what are we going to do with it when we get in there? A lot based upon the preoperative imaging, But then also for me, it's once I get them asleep, I double check my range of motion and make sure that I'm not missing that subtle thing of range of motion block that I can easily accommodate by just how I invert the acetabulum or do something different for the coverage. The coverage you're really looking at, though, what you have to assessing the drop release still, for the most part, is just fluoroscopy. And you're going to do your osteotomy and you're going to set it in place where you've got to look for the basic radiographic parameters that you're trying to match to make it look normal. You want a flat source seal. You want the posterior wall hitting the center of the head. You want and I'd say the flat source seal on both the AP and the false profile, just to say, yeah, I have what looks like something I want to see in the post-op on regular radiographs. And then making sure the other subtle pieces of PAO business are intact. But we don't need to get into all the details there. But essentially, you want to look for the basic parameters that you would want to see on a normal hip X-ray.
Makes sense.
I'm still blown away by, what'd you say, an hour and a half? Like an hour?
Yeah.
Yeah, I think honestly, my pride of everyone likes to brag about their stuff. It's not really bragging. It's like, I was talking, so I got to know Gons over the years, and I'd seen in meetings where we sit in the back row and it's sort of like bend his ear about stuff. He's like, this surgery's not so hard. It's like, but you have to have leathery skin to do it.
Yeah.
Because even 15, 20 years ago, people were like, you're doing so much, this is worthless. What are you doing? Just do hip replacement. But the reality is, you can do the surgery if you have a system in place, 45 minutes to an hour if the cuts go smoothly. I mean, an average size female patient with left hip dysplasia, kind of a typical hip dysplasia patient, the section goes smoothly. Your cuts are done in 45 minutes, hour, and then you're closing in half an hour, and then that's kind of it. If I'm opening the joint to look at something, I think it's kind of adds a 15-minute piece to it. And truthfully, the way we train it now, I think the goal is, frankly, that you got to train it the way you want to do it, right?
Yeah.
So you don't go everybody trains differently, and this is off. Like, I guess I want just to say how I think about this. When I was a fellow, I wanted to do hip, I wanted to do spine, but I knew I was going to come out and do a bunch of everything. And part of that everything was complex club feet. Did you ever see that surgery when you were children?
Yeah.
Like the little Cincinnati incision on the back?
Oh, yeah.
It's tiny little stuff. Did you ever get to scrub with Dr. Kasser for one?
Yeah.
Did you ever do one with somebody else?
May.
Yeah. Different, right?
Yeah.
So Kasser, it's always, for me, when I was a fellow, it was like, it's an hour and 26 minutes on to try and get whether he's doing it or you're doing it. And he's like, boom, 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 boom.
Yeah.
You just learn how you do it.
Yeah.
And if you're not doing it the way he does it, he's like, he has a subtle way of kind of showing you, like, no, let's want to do it this way. Yeah. And what I tell trainees is like, look, you don't come here to kind of figure out how to do a PAO.
Yeah.
You came here because we do a lot of them, and we do it efficiently, and you want to learn to be an efficient PAO surgeon.
Yeah.
So I'm going to teach you. You're just starting, like we're just starting fellows now, like new hip fellow, new piece fellows. They want to do it. It's like, okay, I want you to learn how to show me the beginning of it, and just do the approach until you make it look like I did it. And then you get there, I'm going to let you set up the first cut, and then you do the first cut, make the first cut look easy, and you just march it on like that. And you can do it now to a point where by the end of the fellowship, you guys, the last hip fellow is one of our previous residents, Miles Batty, and he's very solid resident, very solid fellow. But the case is getting done in the same amount of time, whether I'm doing it or he's doing it, and that for me is a success. And I want to get to a place. I think our success in PAOs is where we get it to a place where it's not like you just blew somebody's life up, but also that you're not sitting there spending your whole day. Like, I could do 3 in a day.
Yeah.
If they gave me an extra hour at the end of my 5 instead of 6, I could do 3 in a day. It's not that hard, and that's with children's turnover time.
Yeah.
So the point is, you want to make something efficient. Like, you don't go in the OR, do a knee scope or a shoulder scope and say, I'm going to mess around and let somebody figure out how to do this. You're like, it's business, and there's a way to do it where it makes sense. And that's how we've kind of evolved the bony procedure into something that we can offer people with mild and borderline dysplasia.
No, I think that totally makes sense. And it's like, when I was going to Vail, that's how I was really intimidated about posterior lateral corner for the knee, because I
Mhm.
just didn't feel like I saw a lot of it. And I felt like, oh God, it just feels like this black box. And LaPrade was like that. He was like, nope, it's bing, 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 bing. And then you're like, oh, this actually isn't hard at all.
That's
It's
right.
just like, just, but yeah.
You
So
find
I'm sure
somebody who's really good at it and they do a lot
Yes.
of it, and you're like, ah,
yeah.
Yeah.
this is easy.
Yeah. Exactly.
Okay, so speaking of Val, okay, so we'd like to talk a little bit more about what the data shows. So Philippon and Vale, he did a systematic review that found there was a lack of consensus in the literature on the best treatment options for patients with borderline developmental dysplasia. However, those outcomes improved across all patient measures, regardless of whether they were a scope or a PAO. So as you sort of indicated before, there isn't always like a clear-cut winner. Like when you're looking at these, like which one should I do? You talked about how you go through a lot of education with your patients, but what are like the bullet points of like, this is what you need to know about scope, and like how, where you think it shines, and this is what you need to know about like PAO, and these are like the great things about it or bad things.
Mhm.
Great question, and perfectly timed after I honestly gave this speech about 6 times today. One, we talked about non-operative management never being off the table.
Yep.
But they got to know that. They don't have to go to the operating. They can work that. They can try to till they're blue in the face. If they find something that works non-operatively, do that.
Yeah.
Surgically, I believe the data and multiple small studies show fairly consistent results, including Mark's data and now up to 10-year data, and Ben Dome's the same.
Okay.
Soshi, Shida, like they're all doing that. They push their stuff out now. And I tell folks it's roughly a 70-30 split. 70% doing great. Scope alone, borderline mild dysplasia. 30% persistent and or recurrent pain in the short term, needing additional procedures. And that could include arthroscopy. It could include hip replacement. And there are obviously small studies, some variability between them and what they had in their patient populations. Some found risk factors for failure. Others didn't look at risk factors. But the bottom line is, if you look at from the 15,000 foot view, I look at it kind of 70-30 split. Now, depending on who you talk to from an arthroscopy side is on the side. Bang Yan is a little more nihilistic. He's like, it's hand waving 60-40. I can make it look different, but I can't guarantee it's going to be better. But I make sure they understand that arthroscopy can be a solution. And we're still struggling to pick out who's going to be a 70%er and which hip's going to be a 30%er. And until we figure that out, I just want you to know that it's possible that you could do this and still have a success.
Yeah.
Third piece is, well, PAO's out there, and success of PAO is high in most studies. However, it's not 100%. And which ones are the ones that are failing? Well, it's a little bit like comparing apples to oranges when you think about success of PAO versus success of arthroscopy, right? Because our data, most of the long-term follow-up data of PAO, look at failure of PAO by hip replacement, progressive arthritis, needing arthroplasty. So that's not necessarily the same thing, right? We're increasingly, though, as we get longer-term data and follow-up on our borderline cohort in the anchor group, as well as other studies, we're finding essentially more or less that 90+% are doing great in the short to midterm with PAO. And are they the same patients as the arthroscopy patients? And I think I think Mark's study kind of brings that point that there's not a consensus. And when I see that, loose example, Perthes disease has been around, known about for 15 years it was published here. Yeah. And we still don't have a consensus statement on how to best handle that. And why is that? Well, there's a lot of variability in it. There's stuff we don't even understand. In the last 5-10 years, EDS and hypermobility has become a thing that we understand more about and how it can contribute to this stuff. So there's things that contribute here that weren't even looked at in those studies, right? The meta-analysis looked at studies, but hypermobility wasn't like one of the tick boxes there. Like, so we have a lot still to learn, but I want to make sure the patients understand like what we understand and what we don't know. And we know a lot. We've seen a lot of success with 2 very safe procedures, and we are still working out which one is probably the best one for each individual hip. But at the end of the day, it revolves still safely around the patient's decision about what they think makes the most sense to them. One side note then is, well, when do I have to add a scope or arthrotomy to my PAO?
Perfect.
Right? Nice transition.
Was a question.
There you go. So,
You want to know.
a couple pieces there. One, for me, I will look at the MRI and say, all right, is there an intra-articular thing that I can't reach through an arthrotomy?
Okay.
Right? So 3 of the 6 people I saw today had a prior hip arthroscopy, borderline hip dysplasia, persistent pain. I don't do a lot of hip arthroscopy, but I know that the anchors and the sutures are oftentimes out of my window that I usually expose.
Mm-hmm.
My arthrotomy is usually rectus and medial. I can sneak underneath rectus to see what's up there, but I can't access the 12 o'clock position to do any repairs effectively. But I can do everything from rectus down to 3. So if they've had a previous arthroscopy and I think there may be some possible pathology there, I'm going to have somebody go in and just look with a camera. If I think that they have something parallel, just something in the front that I can easily access that I think needs to be treated on MRI, I'll do an arthrotomy at a time. Yeah. Tongue in cheek, the other piece is who they got referred by.
Yeah.
Oftentimes they come from an arthroscopist, and they were sent to the arthroscopist because you have a labral tear and you got to have somebody to do arthroscopy to repair your labrum. And then they come see me and I say, well, you have dysplasia. We got to correct the dysplasia. I think would make the most sense. And then they say, well, okay, so who's going to do the arthroscopy?
Yeah.
And I'm like, well, the truth is, and you guys have seen enough hip arthroscopy, it's not always some big floppy tear in there. It's pretty rare that that's the case, honestly. It's more degenerative change, something that looks a little bit floppy. Maybe I'll go and do a repair. And my old friend Bang Yen likes this sort of joke, I think the biggest part of this repair is the acetabuloplasty prep. Where I take my thermal wand and I go and I hook all the pain receptors on the periphery of the labrum.
Yeah.
Get in there and look at the acetabular rim. And I think biology, physiology, there's probably some merit to that. And, we're reconstructing these labra, sure, they're not going to be pain the labrum anymore. So getting back to it, sometimes I just say, look, I'll just look at it.
Yeah.
Most of the damage looks like it's degenerative changes in the front. I can see that. I open up the joint. I put a probe on it. I tell them if it's unstable, it's detached from the bone, I'll put a stitch in it. If it's not, I'm not. Why not? Well, actually, to put the stitch in it, I have to take a knife and detach it from the bone to put the anchor in, then put a stitch in it to get it to reattach. And they usually kind of get that.
Yeah. It's like fixing a partial rotator cuff tear.
Yeah, exactly.
Right.
And it's more down.
Point. And so I also reflect and say, look, hip arthroscopy started taking off in the early 2000s. PAO started in the early 80s.
Yeah.
Right.
Yeah.
And so we didn't really have a lot of hip arthroscopy for the first 20 years. Yeah. And looking up at Dr. Mellis's stuff that I did, a vast majority just get better when you unload the labrum.
Yeah.
They have labral irritation. I say, look, it's not a full thing there. It doesn't mean it doesn't hurt. It just means you don't necessarily have to put something in there to stitch it back. It just needs to not be walked on anymore.
Yeah, not loaded.
And it seems to do a great job with that. So I'll tell them, look, it takes 15 minutes. It's not a problem. I'll go look in there, just put a probe on it. If I look, it's fine. I put some resorbable stitch. It's good. And that usually seems to carry the day there.
Yeah. I think back to the biomechanical problem,
Exactly.
So we're going to finish up with one of our like favorite sort of
Mm.
aspects, and it's all like the nuance of like return to activity, recovery, like, returning to sport, if that is what they're interested in. So we're going to, give you the scenario of there's a labrum repair, there's capsule plication and this borderline patient. Like, what do you talk about with like restrictions? Like, are there things that you say you're never allowed to do this again, or nope, you just got to wait this long? Like, how do you sort of modify their return to sport, as well as a side question of, do you brace?
Do I
Brace.
brace?
Yeah.
Okay. So as I was mentioning before, I try to keep my post-op PT protocol very straightforward and simple, because I don't know where they're coming from always, and I don't know if they have somebody out there that's ever even heard of a PAO.
Yeah.
So if I just talk about PAOs for starters,
Okay.
actually I'll stop. I'll reverse a little bit.
Okay.
You asked about soft tissue management. People had a labral repair and capsule plication.
Mhm.
So if they've had a capsule plication, soft tissue management only, and they want to slowly get back to sports, that's where we would traditionally use a brace just to limit motion so they don't yank on the repair. I tell them, look, this is just your external reminder of where not to put your hip for the next couple of weeks while we give the soft tissues a chance to stick back together. Then we start progressing their PT with an idea of slow progressive weight bearing, and then over time, after 6 weeks, start to slowly increase their strengthening piece and their flexibility piece. All right. Goal is getting back to all sports and activities. I don't want them to come to me and say, well, I'm a hip replacement patient, I can never do XYZ anymore. This is your hip joint. Our goal is to preserve your joint and let you do what you want, with some rare exceptions. So if we're just focusing on borderline and mild dysplasia, and you don't have bad arthritis, I want to get you back in it. I want to reset and make sure things are set up where you can actually function, do what you want to do. If we're talking about now osteotomy patients, I'm presuming that I'm buying bony stability. I'm not going to have to rely as much on the soft tissue envelope anymore. So I won't brace them. And there, my PT prescription is very straightforward. It's, I got to rest you for 4 weeks. So you have some basic range of motion limits, 90 degrees of flexion, full extension, 20 degrees in all planes. That's just the boilerplate. That's so I don't stress the repair. Then after 4 weeks of bone healing, you get an x-ray. I literally tell the medicine folks from across the states to say, stand up, balance with your crutches, and put equal weight on both legs. And if it doesn't hurt, you're good to go to start PT. In the vast majority, it's good to go. Then you send them your PT prescription, and phase 1 is, let's get you off your crutches, let's get you walking, let's get your range of motion back. No, let's get you walking without a limp. Yeah. And I tell folks, on average, that's the next 6 to 8 weeks.
Yeah.
Teenagers are cheating by 4 weeks. They're kind of walking, they heal aggressively. They're like, oh, I kind of been furniture surfing for the last couple of days. And they truly, for the most part, do kind of fly. My 20-year-olds are very solidly in the 6 to 8 week march. My 30 to 40-year-olds are kind of maybe pushing a little bit more, with dependence upon what their prehab was. Then now you're about 2.5 to 3 months out from surgery, and recheck your x-ray, make sure you're making progress off crutches, or nearly so, maybe one crutch for longer distances. If that's where you are, no other issues, here's phase 2. Ramp everything else up. Weight bearing and range of motion is tolerated. Strengthening, proprioception, gait training. Let's get the rest of the basic life mechanics down. If you're an athlete and you want to get back to a certain sport, let's start adding in sport-specific strengthening and motion stuff. What about getting back to higher level sports and activities? Our data in other places, at least 80% return to high level sports and activities after PAO. Can I go back to being a professional athlete? Yes. Time to get there. My shtick is, look, the higher the level of activity you want to return to, the longer it's going to take to rebuild and re-strengthen those very specific muscles that not everybody else uses in daily life to get you to that level of performance. So we've had professional athletes get there. I mean, you guys have probably come across this in your sports lives, like professional ballerinas, a lot of them have dysplasia. And the mantra is, don't go to the orthopedic surgeon ever. Right? Some of them actually get to a place where they actually have to have something. Like I have one New York ballerina who finds like, I can't walk down the street. My hip feels so sloppy. And worked with a PT who was a former professional ballerina in New York and got a PAO that I designed for her, set it up with a range of motion restriction that she was going to need. So I didn't block that. And she got back, she got a contract, but it took 2 years. So I tell them, look, you can get there, but if you want to get back to even, I don't know, collegiate D1 levels for it, it may take you not 5 to 6 months. It may take you like the next 8 to 12 months, depending on what you needed to do. But it's doable from a biomechanical standpoint.
So, it's like a UCL. Like it just like you can get back with a UCL, but like it takes forever, you know?
Right. Like you think it's going to be, it's just a simple little surgery, but actually there's all the other stuff around it that has to support it. And, you know, you're saying UCL, right?
Yeah, UCL.
Yeah, I mean, like, so my boys are pitchers.
Are they?
They're 11 and 12, and here's the shining star pediatric orthopedic surgeon. Both boys have rehabbed an elbow, and the older guy's a shoulder as well. Yeah. And with bony changes on X-ray, the whole thing. And I've come to get to know the rehab very, very well, not having trained in that. But to your point, like there's a lot of stuff around it that you have to pay attention to, and it's not stuff you automatically go to from a strength and conditioning standpoint in your day-to-day.
I would always, I remember when I was still a PT, the thing that would strike me is like when you would see a pitcher, how asymmetric they looked like from behind. You know, you're just like one side of their glutes is like huge. The other, you're just like, it's just like the whole body, you know, it wasn't just like elbow, shoulder. It was like the whole thing. It's such an asymmetric exercise. My sister was a college pitcher and it, you know, same thing. It's just this weird, you know, kind of motion that your body is like, what are we doing? You know?
I'm struck by it. And I guess getting back to your question, like I think the rehab piece of it can get you back to almost anything you want to do after a PAO. The soft tissue piece, I think truthfully, I'd have to almost lean more on my hip arthroscopy colleagues just because I don't see as much of the soft tissue stuff, soft tissue only stuff. But I can tell you, at least from our data in the PAO world, it's very, very doable.
Yeah, that's great. Yeah. Great news.
That's awesome. Well, that was really helpful. That was a great overview of everything. That was really awesome. Catherine, do you have anything else you want to add or
No, I was just going to say like it, you know, we feel like so blessed in a way to like, we get to have these discussions. Like this is like residency, right? It's like being at core on a Wednesday and just like going through like, all right, let's talk about physical exam. Let's talk about what's the literature showing now. And so it's like a masterclass that we just get to have an inside seat. So we appreciate it and all that, you know, you taught us when we were residents, but also like just having a continued relationship with you as we've been out in the world. We're just super grateful.
Yeah.
Well, this has been awesome. I've been following you guys and seeing your post and your podcast, and it's fun to see like all the familiar faces and hear you guys again after all these years. And sort of relish in your success peripherally, but also kind of see all our other friends that you guys invite on and people that we all know, and also kind of hear about the stuff that I've not been around for a while. Like, I mean, men's podcast was like, oh my God, there's so much other stuff in what sports medicine. Really just forgot.
That was a great one.
Yeah, he did a great job, and you know, that's one. That one blows my mind too, like, because I've known him since, you know, before, like when I was thinking about going into medical school, and I'm just like, you know, you just, again, you feel lucky to like be around people like you and Min, and, you know, children's is such a special part of our residency. I don't, you know, obviously like, you know, Tufts is going there now, BU is going there, Dartmouth is still going there. Do you still get folks from New York coming up?
Yep, I think so.
Yeah. So
Wow.
it's just, Boston Children's is such a special place, and it's filled with like so many special faculty. So it's like, yeah. So we're really blessed with that. So thank you.
And I don't know, Travis, if you know our origin story of how we got into doing this podcast, but Catherine and I would like chat after we were both done with our fellowship. We were in practice and we were talking, and we were like, we kind of miss like the journal clubs and like the academic discussions that we would have, because we trained at such an academic place. Not enough to go back into academics, the two of us, but we really, yes, exactly. But and that's kind of how this got started, because we were like, we want to connect with those people again. We want to have these discussions. We want to like make sure our community is updated on the most recent literature and not doing what they did 15 years ago, So that's kind of where it started, and it's really expanded, and we just feel really grateful that we're able to do this. So
no, that's awesome. I hadn't realized that. But I can see that completely with the two of you guys in particular. And it's cool that you guys took advantage of the ongoing social media piece of it to kind of not just have it amongst yourself, but share it with everybody else. Like I think it's been awesome, and I'm glad I found it along the way. And I'm like, boy, this would be a cool place to talk about mild dysplasia, because I feel like I'm still seeing people send me patients like, oh, I had 5 hip arthroscopies, and you got terrible dysplasia.
The community, and we have a lot of PTs that listen to, and I think PTs are great educators to the community as well, because sometimes they're they're the gatekeeper a lot of times of saying, oh, this is who you should go to, and so it's helpful.
Yeah, for sure. Definitely. Well, thanks again, guys. This has been awesome.
Thank
to see you guys, and glad that you guys are doing so well. I wish I got to more sports medicine conferences to hang out with you dudes.
Yeah. Well, it's good to connect.
All right.
I'm good. Hits.